teaching point that I make that would be very helpful. A tumor the size of a dime, which we call an early cancer, has 1 billion cells. It's taken 5 to 6 years to get to that dime-sized mass. If it's benign and we ignore it, it's okay. But if it's malignant and ignore it, you may die. It's clear that most of these stage 3 melanomas, which remember 20 or 30 years ago, those individuals, only 20% of them were alive 5 years later. So now 95% are alive with non-surgical treatment with immunotherapy.
Are you influenced by Angelina Jolie? You can be honest. Lots of people were. When she was open and wrote in the New York Times about her prophylactic preventative mastectomy and removal of her ovaries, it influenced and drove a whole spike in people asking, should I do that too? And now she's starring in a movie, Couture, that features her as a woman who discovers she has breast cancer. And the movie has created space for her to talk about her genetic history with her children. My guest today spent 50 years cutting out tumors as one of the pioneers of surgical oncology. Today, he's going to tell you how you can know your risk before there's any symptoms and why you have to. So I have to imagine, Charles, there was a lot of skepticism or resistance. I mean, as you said, surgery was the one thing you knew for sure worked. You've told me about having to re-educate the whole field and convince surgeons that, this new research was good. Before you started teaching others, was there any part of it that you were holding on to that was hard for you to let go of and helps you empathize with what those other surgeons are going through?
Well, it's a very dynamic thing because your base of your skills is what you've learned in the traditions that got you to this point. But you really have to think about what is best for the patient and what are the shortfalls of our traditional treatments and how can we make it better. So I've been a change agent all of my life, and I understand that sometimes changing tradition takes time, takes persuasion, takes more than my own opinion, but to build a consensus of individuals and experts, not only from other institutions in the United States, but collaboratively across the world, because there are still people in many parts of the world who say, well, you could treat people better in America. I can't relate to that. Unless we can engage them and show that the standards of care that we're trying to create equally apply to patients wherever they live.
Well, but Charles, do they? Because immunotherapy, which is the key to this breakthrough in melanoma, immunotherapy is new, patent protected, expensive. How does this become accessible everywhere in the world? Because melanoma doesn't discriminate by where you happen to be living or born. Hey, it's Joelle. Before we get deeper into the episode, click the subscribe button and be part of our growing community of people committed to ensuring everyone can kick cancer's ass in whatever way. And you would help me a ton if you'd leave a review or a comment. If you're on Spotify, please give me 5 stars. If you're on Apple Podcasts, 5 stars and write something. If you're on YouTube, please give it a thumbs up and write a comment. This helps so much. And if you want more kicking cancer's ass, you want the in-depth analyses and articles and resources, go over to kcapodcast.com, take a look. You can subscribe for free, or you can become a paid subscriber and get the really meaty, good stuff every week. Thank you for being here. Let's get back to the episode.
You're absolutely right. And that's part of the evolution of a new therapy. It is expensive. It takes a new skill in order to manage it. You have to understand how to manage the symptoms, because part of immunotherapy is it creates autoimmune diseases as the side effects, thyroiditis, cutaneous and liver abnormalities, pneumonitis, and so forth. So you have to learn how to manage these things and to select patients who you can get through this safely. Any new therapy like this, which is revolutionary, and applies to many cancers worldwide takes sometimes for education. You have to educate with evidence. You have to engage more and more experts in a wider audience, and then have them tell their spheres of influence this is what we should be doing in our cancer center, in our country, because it's the best thing for our patients. Anything that's new, because it's patented and expensive at first, as it becomes more widely distributed, becomes more safer, wider indications, and becomes less expensive. Now, we've been doing immunotherapy now for almost 20 years, but now I think it's more widely available in most countries around the world. It is um, less expensive, but I think the insurers and those who are paying the bills understand that there's a benefit of this that makes the cost of immunotherapy worthwhile compared to the cost of other treatments, such as traditional, more toxic chemotherapy.
Yeah, I don't know that people really understand the difference. And would you spend a minute and explain what's the difference between immunotherapy and
Sure.
chemotherapy and kind of how it impacts particularly working age people who are being treated?
Sure. And, the first thing I have to teach people is that immunotherapy does not treat cancer. You can't treat it as a cancer treating agent. It treats a dysfunctional immune system. And one of the things that I learned that people can relate to, everybody knows that if you're allergic to grass or dust, you go to the allergist who gives you low doses of grass or dust so that you become tolerant. So if you go out in a field of grass, your immune system doesn't recognize it and doesn't respond. And so too, we've now learned that the cancer cells that survive have done so in a variety of cancers by releasing low doses of their tumor antigen and inducing tolerance so that the immune surveillance functions, which protects us, will not recognize cancer cells and allows it to grow without any checks or destruction. But on the other hand, if we can turn off that tolerance or break tolerance, the immune system can destroy large amounts of tumor very quickly. So it's a complementary treatment to treating cancer. When we treat cancer with drugs, radiation, and so forth, it actually breaks down the tumor cells, releases antigen, and gives an internal boost to the immune system in the presence of a checkpoint inhibitor that's broken tolerance. So now we use combinations of treating the cancer on the one hand and breaking tolerance so the immune system can do its job that it's programmed to do by destroying any foreign antigen, whether it's a cancer cell, a virus, a bacteria, or a transplanted tissue.
So, in the case of melanoma, where, 6 weeks of immunotherapy could eliminate 70% of stage 3 tumors, that is actually fixing the immune system. So, the immune system eliminates the cancer rather than trying to attack the cancer directly. Do I have that right?
It's exactly right. And I wish other cancers were as simple to treat as what we're learning with melanoma. But it's clear that most of these stage 3 melanomas, which remember 20 or 30 years ago, those individuals, only 20% of them were alive 5 years later. So now 95% are alive with non surgical treatment with immunotherapy because we've learned in that disease, in that condition, the reason those cells can grow is because they've induced tolerance, and therefore the treatment is simple. You break the tolerance, the immune system does its job that it was programmed to do in the first place.
One of the things that I was so excited about when my oncologist included Pembro, Keytruda, in my protocol for my cancer was that it was a way to train or fix the defect in the immune system that could reduce the probability of recurrence because the immune system knew what to do. Is that a specialty of Keytruda or is that consistent with the other immunotherapies like what you're talking about for melanoma?
Now, these checkpoint inhibitors, there are two of them. They work at different places in the immune system to break tolerance, and we're getting more sophisticated with more agents to understand the immune system. But these two are common to all the cancers. They work in the same mechanism. And in breast cancer, for example, they don't work in many types of breast cancer. So we have to be selective. We have some rather crude tests that predict the risk for tolerance in giving immunotherapy. But by and large, it's restricted to the patients with the so-called triple negative breast cancer and a small percentage of individuals with a HER2 positive and the ER positive. But we're getting better at understanding the functions of the immune system in immune surveillance and why it has failed in individuals with cancer and how we can correct those abnormalities in different ways so it comes alongside our other cancer treatments that are directed at the cancer cells itself.
And one of the amazing things, among others, of the immunotherapy revolution is for most patients, not all, the side effects are non existent. Obviously, there's things we have to look at, as you were talking about the thyroiditis or other tests to ensure that you're in that group, but it isn't like chemo where you're getting nauseous or neuropathy or you have to worry about hair loss or mouth sores. At least for a lot of patients, the immunotherapy is kind of a non-event.
Yes. Well, we know one of the functions of the immune system, we have normal cells that break off and release organ specific foreign proteins like the thyroid or the lung. But our immune system from the time we were born becomes tolerant to those normal proteins, so it doesn't react to it. So, one of the side effects is when we break tolerance to tumor antigens, sometimes there's a crossover and we break tolerance to those immune systems that begin to react to some normal tissues, such as the lung or the thyroid and so forth. So it causes what we call autoimmune diseases that we could treat with steroids. And the key thing for patients taking immunotherapy, if they understand that there's a change in their lifestyle, in their symptoms, and they talk to their doctor early on, this autoimmunity can be reversed with a simple treatment with steroids. And once those autoimmune symptoms have gone away and been reversed, you could go back onto the cancer immunotherapy. And so, too, later on, if somebody has relapsed from their cancer, you can give the immunotherapy again, which we would not do for standard chemotherapy. And that's why I think everybody has to understand that immunotherapy is a different approach. It doesn't treat cancer, and the rules of our engagement are very different. And once we understand them, then we can use them effectively alongside our more traditional targeted therapy against cancer cells.
I love that. It's a different approach. And something you mentioned, Charles, immunotherapy isn't a blanket solution. It's actually not only cancer specific, but tumor pathology, or what I've been hearing in the cancer world, the molecular characteristics
Yes.
of tumors. Now, you've made a fairly significant shift as you are retiring from MD Anderson and committing the next stage of your career to ISOPT. What was the trigger of this shift to personalized screening and knowing your risk and prevention interventions?
Well, that's a good question, Joelle. In my early career, most of the people I treated were older and retired, and they'd had a good life. But over the past decade or so, I'm seeing more and more tragedies of young people in their 30s and 40s, moms and dads, people at the peak of their career who are dying of cancer because they were waiting for symptoms. And I think that what we have to send as a message is that cancer is a silent disease. And if you wait for symptoms, you're really talking about advanced cancer. So I understood that as the cancer epidemic is increasing in the younger age population, in the working age population, people in their 25 to 50 years old, that they're waiting for symptoms. And because of that, they're not part of screening programs. And we're losing an entire population of our working force because they're outside of the age guidelines. And I've realized that we have to move in a new direction as the cancer epidemic is shifting from the older age population, where we're doing a good job because of screening and prevention interventions, to understanding who among the younger population is at increased risk for cancer and engage them in standardized ways to intervene with prevention, intervention, and with screening so that they can have either prevent their cancer or detect it at an early and curable stage. So I think this is the new approach that we have to take over the next 10 years. And there's a dichotomy. Cancer is moving now because of environmental influences and other things into the younger population, many of whom are outside of our age directed screening guidelines. But here's the problem. We can't afford to screen everybody in that age group. So we have to identify who is the 10 to 20% of healthy individuals, asymptomatic individuals, who have inherited increased risk for cancer and whose lifestyle increases their risk for cancer, and tell them 10 years before they would get cancer, you need to start now of understanding how to change your lifestyle, lose weight, drink moderately, exercise, and get into screening programs because, for example, we could prevent colon cancer by removing polyps. We could detect breast cancer when 95% are curable with mammograms, but you can't feel them. You have to detect it with a AI-enhanced mammogram or an MRI. So I think our shift is now, how do we identify the individuals at higher risk in the younger population and get them into prevention and screening programs, because you can't use the blunt criteria of age to identify those individuals.
And there are some exciting prevention interventions as well if you are high risk. I mean, it used to be high risk for triple negative breast cancer. Your options were surgical. I mean, screening, of course, but if you wanted to radically reduce the risk, you had to do preventative surgery, which in triple negative still is the case, although I think there's some exciting things coming. And if you're curious about that, go watch Dr. Abby Liberty and Dr. Sasha Howell on earlier episodes of Kicking Cancer's Ass. However, for cervical cancer, the HPV vaccine can truly eliminate this cancer. We see, there was something we were just talking about with EFGR lung cancer with an antibody, or baby tamoxifen for ER positive people with high probability of ER positive. What are the other prevention interventions beyond lifestyle that are targeted for specific risk populations?
Well, the number one thing is smoking cessation. We
Of
still
course.
have too many people who are smoking. And I'm very worried about the younger population who think that vaping is safe. We're going to have a whole new epidemic of lung cancer in the younger population because of vaping. It won't show up for 10 years from now, which is exactly what happened in the 40s and 50s with smoking. And then all of a sudden people said, well, why did you do that dangerous vaping? Because right now the marketing says it's safe. It is not safe. It's destroying your lungs. It creates inflammation, and that will lead 10 to 20 years later to lung cancer. The second epidemic that we're going to face is the obesity epidemic. Right now in America, 45% of all Americans are categorized as obese. And in 10 years, that will be 60%. We now know the scientific linkage between obesity and the changes in the intestine, the inflammation, the changes in the microbiome in our gut that changes and reduces our immune surveillance that leads to 14 different cancers. So we're going to have an epidemic of cancers because of obesity. So we're now, I think, going to have a revolution of obesity interventions with a variety of tools. The GLP-1s are one of those, but there'll be a whole lot of tools and interventions to help people in their lifestyle. Obesity is just the endpoint of causing inflammation and changes in your gut that leads to cancer, heart disease, diabetes, and so forth. And this is something that we have to face. The highly processed foods are as bad as smoking tobacco five packs a day.
Wow. Um, so basically, eat real food, right? Michael Pollan, eat
And
real food,
it's like
preferably
anything else.
vegetables.
Do it in moderation. It's when you depend upon the cheap, highly processed food as your staple 3 times a day, and that's all you eat. You will pay a price for that some years later because of the chronic inflammation you've created by eating the wrong foods. We have to remember that the younger population, and we have data that anyone born after 1960 is going to be having a rising risk of colorectal cancer and other cancers because of the highly processed foods, the dyes and the preservatives, the things that we're taking in our mouth each day that are having um, pollution and inflammation to our gut that is going to pay a penalty some years later.
All right. So don't smoke, lose weight, don't eat processed foods, and
Drink in
I would
moderation and exercise.
and exercise. And then I would add know your risk
Yes.
because particularly if you live in a country where it's available to get genetic testing and your privacy is protected against discrimination or any other use of that data.
And this is a very good point. I think we give general messages and people say, "Oh, I'll be healthy later on in life, but I'm feeling good right now." But I think if people know their specific risk, they're more likely to intervene and do something about that risk. So, for example, I have 4 generations of heart disease in my family. I started doing prevention 40 years ago. And here I am at this point in time, my coronary arteries are open. My blood vessels are soft. They don't have atherosclerosis. But I inherited a risk for that killed many of my ancestors because they didn't have prevention. And I think it motivated me to do that because I knew my specific risk. And that motivated me to do something about that beyond the general health messages. And so I think your point of knowing your risk can motivate you if you have a specific risk for breast cancer, colorectal cancer, thyroid cancer, gastric cancer, whatever, then you at least need to do something about that risk beyond the general health messages.
Right. And the general health messages are a good idea
Sure
for
they are.
everybody. I think the knowing your risk is very motivating. It also, when you know your risk, opens reimbursement pathways for a number of the prevention interventions like advanced screening.
I mean, a good example, Joelle, is if you have a family history of colorectal cancer or the genetic inherited risk for colorectal cancer, it's likely that you are developing polyps in your colon. That's the precursor of colorectal cancer. Those can be removed as prevention, and you will never die of colorectal cancer. But if you wait for symptoms, the symptoms are because of the spread of colorectal cancer, and you'll die. And now colorectal cancer is occurring in people in their 30s and 40s. And so I think the whole point is if you know your risk and if you have a higher risk For colorectal cancer, is just one example, or breast cancer, you really need to do something about that risk, regardless of what you do in your general health, because that is likely to be the cause of your death. And if you know about it, you could do something to prevent it or diagnose it at a curable stage so you can go on, live longer, have a better quality of life, and at least die of some other disease, but not the disease that you begin to have a higher risk for.
Now, one of the challenges with the alarming rise of colorectal cancer in people under 50 is that they are overwhelmingly not having genetic or family history,
Yes.
and they're not particularly unhealthy.
Yeah.
I was talking with the American Cancer Society yesterday, and apparently the standard is everyone should do a FIT, a fecal test,
A fit.
every year, a FIT test. I, I don't think I've ever had a doctor ask me to do that as part of my annual. Where's the disconnect between, this is a cheap, okay, a little bit gross, but cheap, easy test that can determine if you should be getting a colonoscopy because there might be something early worth looking at.
Right. And this is also another good point. We can't afford to do colonoscopies on everybody for screening. It's very expensive, and it requires anesthesia, a lot of prep, and a skill with the endoscopist. But we will be doing more and more in the future, especially as we define specific risk of looking at the stool, of the blood, and even there are now commercially available tests for taking your tears and determining a risk for breast cancer before you develop breast cancer. So we'll be doing a lot more screening as the starting point for things that are reasonably inexpensive, not as big an intervention for the individuals, because nobody wants to have the prep for a colonoscopy unless they absolutely need it. But I think it starts with knowing your risk, and that within that risk portfolio, having the screening, doing the most simple and least expensive screening, so that if you start to understand that you have a risk for a specific cancer, then you go into the more detailed screening tests, the interventions like MRI screening or colonoscopy or endoscopy, which you wouldn't do for everybody. But as we understand specific risk categories, then we could justify doing that in those individuals, and they benefit from it. But we have to get away from the one size fits all, because we can't afford to screen everybody. And it really turns off a lot of the population, because, the whole population doesn't want to have a colonoscopy, but some people need it and benefit from it. And it's how do we identify that group of people that do benefit and that will go through it because they will benefit from it?
Well, and I want to invite everyone for your annual physical. Ask your doctor, are we including a fit test?
Yes.
Because that is the best way to know if you're in the group that needs to have a colonoscopy, because there's a signal, right? That's a looking for a early signal of something that needs investigation, just as a self-exam for breasts can be an early signal if the mass can be palpated.
You raise a good point that I wanted to communicate to your listening audience. These tests, like a mammogram or the blood test, will tell you at that moment you don't have cancer. But it doesn't mean that a month later or several months later you haven't developed a cancer. That's why we have to repeat those. I think the most important thing for all of us is to know our inherited risks. The combination of the genes we inherited from mom and dad and our family history, because that's a lifetime risk as a starting point. Then you add your lifestyle risk and your age, and then I think you can have a more precise plan of what tests do I really need to get. I may not be able to get all of them, but I want to be sure that I get the specific tests that match my specific risk. Know your risk.
Makes complete sense. So let's talk about a story, another problem in the world of cancer, which is the response of you're too young. You were telling me about a 32-year-old who was pregnant, was high risk, but found a mass. The doctor said, you're too young. And, people think, I'm in my 20s, 30s, 40s, I'm too young. How do we deal with the medical community? I mean, look, cancer is still rare, thankfully, among younger people. But the you're too young, that can't possibly be it. I mean, that was my sister's story, and she had to push for surgery. They didn't even do a biopsy. Your 32-year-old that you're talking about, I mean, people clearly aren't too young.
Well, it's our job in the medical community to educate doctors. The problem in that example, because I've been treating breast cancer for decades, most of the breast masses that I see in the middle-aged women are benign disease, fibrocystic disease, and so forth. And it's only the occasional one that comes along with a mass that's really cancer. So that's why doctors, in their busyness of their practice, say, well, you're too young because most of what I see in your age group is benign disease. And I think we have to get more precise in our diagnostic tests. And a lot of this is intuition on the individual patient's part and on the doctor's part. This is a little different, and maybe we should rule out to make sure it's not cancer. Because if it's benign and we ignore it, it's okay. But if it's malignant and ignore it, you may die. So I think we have to be better and maybe more aggressive in the younger age population of intervening with a biopsy to make sure that the masses that we're seeing or the symptoms we're seeing aren't cancer. Because we're seeing now cancer in the younger population. It's emerging, and we need to educate doctors to be more aware and more assertive about diagnostic tests in the younger age population with new masses that are asymptomatic. Remember, cancer is a silent killer, and we are looking for asymptomatic diseases of a small amount. One teaching point that I make that would be very helpful: a tumor the size of a dime, which we call an early cancer, has 1 billion cells. That's what we call an early cancer. It's taken 5 to 6 years to get to that dime-sized mass. And so that tells you why it's so important to diagnose cancer early when it's asymptomatic. It's not pressing on nerves. It's not causing any problems. It's when it spreads and it interferes with vital organs or presses on nerves, that's when it's too late and at an advanced stage. So we want to get cancers early, and we want to get it when they're small and they have not causing any symptoms. And we could only do that with diagnostic tests and awareness of the public to be very aggressive about knowing your risk and getting into screening programs or in prevention intervention programs.
So, another point is, instead of saying you're too young, for example, if it's a breast, the Aurea tear test is a non-invasive and not terribly expensive. So you could say, all right, well, let's rule it out. Let's do the tear test, or let's do a liquid biopsy and
Exactly.
see if there are any markers that this might be not a benign mass. Because biopsies, like colonoscopies, are expensive. There's anesthesia involved, there's time involved, and we do have a high it's a low rate of false positives, but because we do so many mammograms, 70% of those biopsies are benign. And that's, I think last time I calculated it, about $13 billion a year, not including time out of work and the mental anxiety.
And the unnecessary biopsies.
Right. I used to call myself a human pincushion. I, uh, I
But
did say,
Joelle, a major advance now is we're doing AI enhancement.
Mhm.
So we're now showing and this is what you might want to ask when you're getting mammograms, is if there's some abnormalities, is this an AI enhanced? This is not a substitute for the doctors, but it tells the doctors more precisely this little mass in the breast among this forest of masses is one that's different from the other masses, and that might need a biopsy. And sometimes AI can pick out 1 or 2 millimeter, you know, grain size masses that are different from all the other masses on the breast and signal this is something that may need to have a biopsy. So I think we're making some revolutions in our technology with AI enhancements and digital imaging that is going to make it much more precise and decrease the unnecessary biopsies that we've done in the past.
I think that's awesome. And by the way, Charles, I used to call because, before my cancer, I was screened twice a year. And I literally would call it my half year I don't have cancer day because I knew definitively on those days I didn't have cancer. And those were always good days.
Joelle, there's a point here. You are at high risk for reasons you've talked about. There's another group of individuals who are at low risk. And I think it's equally important for individuals who understand their risk in those circumstances where they're at low risk. It's safe to put off doing your mammograms until you're 50 or 55. And that would avoid unnecessary tests, unnecessary anxiety. So it gets back to getting away from the one size fits all and calibrating what we do, when we do it, and how often we do these tests according to personalized risk.
Absolutely. And I think the future is personalized medicine, which used to be prohibitively expensive. And now it's becoming well within reach everywhere in the globe because of lower cost screening. I mean, even the genetic sequencing. When I did it, just to know about the BRCA1, BRCA2, and one other gene, it was $3,000. Now you do the whole genome for $250. Like these numbers are coming down, as you said.
Well, and I think everybody has to be informed and actively a participant. You can't go to the doctor and just say, whatever you say, doctor, because they'll tell you the general approach. But everybody has to understand and take a personal responsibility for awareness and participation. And that's the only way you're going to be healthy. If you take the responsibility for your health and are very proactive about what you need to do about your health, starting with knowing your risk.
And taking responsibility for your lifestyle choices,
Yeah.
right? Like those are things you can control. When we had, I think you know him, Dr. Jay Harness, on talking about, the unbelievable impact that exercise has on reducing recurrence and improving response to treatment, besides which it's overwhelmingly good for you across the board. But, they used to tell people, take it easy. And the inverse is actually true. No, go out and exercise. I know you feel like crap, but go out and exercise anyway.
And, this is a very good point. Knowing your risk is the starting point. It's not good enough just to know your risk. The next step is, what do I do about it in terms of prevention, intervention, and risk-based screening? So it's a whole equation of starting with knowing your risk and then being actively engaged in doing something to lessen that risk and living a better quality of life and a longer life.
Absolutely. So you've said half of the 18 million cancers diagnosed a year could be prevented or cured with what we already know. And you've said to countries that say they can't afford prevention can you afford not to? So for someone who's listening that isn't a policymaker or a CEO, just someone who wants to lower their own odds, what's the first thing you'd tell them to do?
Well, one of our messages right now is you can't afford not to get into prevention and screening because the epidemic of cancer is increasing, and it's increasing in the working age population, which is going to affect every business, every community, and every country in the world. And so we need to have a better message to get the attention of governments and the business community and the public to be more proactive about cancer prevention and early detection. it's not good enough to say we can't afford it, because we will otherwise pay for very expensive treatment for advanced disease, which is which will not cure and is very expensive, very intensive, and causes disability. So the economic equation makes so much sense. Rather than paying a lot of money for something that will only prolong your life but will not cure you, why not invest your money, your health insurance, and your health benefits, and the workplace culture to uh, have a culture of prevention and early detection? It makes so much economic sense. And it goes to productivity in the workplace. It leads to better quality of life. That means moms and dads who will otherwise die are not going to leave orphans. That means even those that are survive are going to take all their life savings that otherwise would go for their kids' education to pay for their expensive doctor bills. So in every way you look at it, it makes so much sense for all of us to invest in the front end, not the back end, but in the front end of cancer prevention, prevention intervention, and risk-based screening for early detection so we can cure individuals who have cancer or prevent it in the first place. And what are the benefits of this? The rules we're talking about for cancer apply equally for heart disease, diabetes, Alzheimer's. So all the things we've talked about of good health and a healthy lifestyle not only benefit cancer, but they affect all of the other chronic diseases that can also affect our lifespan and our quality of life.
I think that's good counsel.
Yep.
And when I talk to people about knowing your risk, one of the things I've had doctors and scientists say is, but, don't people get kind of depressed or despondent if they find out they have a high risk? And I was talking to Kathleen Blazer at City of Hope, and they've done actually extensive research on this question, which I think is worth sharing, because what they find is the initial moment you find out you have higher risk is sometimes a shock, and sometimes there's a moment of grief. But very quickly, people overwhelmingly and statistically significant volumes transition to a feeling of empowerment
Yeah.
and motivation.
It's a gift.
It's a gift. And so I think it's great to know your risk. All right, Charles, we're going to switch to the lightning round. You ready?
Okay. Sure.
Okay, here we go. Quick answers. The most underrated weapon we already have against cancer is?
Genetics testing and prevention intervention.
Complete this sentence. The biggest myth about being too young for cancer is?
I'm waiting for symptoms. That's too late.
Okay, Teddy Roosevelt or Winston Churchill, whose leadership did you reach for as you led at MD Anderson, at City of Hope, and now with ISOPT? You reach for it on a hard day.
Well, I teach about leadership, and Teddy Roosevelt and Winston Churchill are two of my models for leadership. And I actually have on my desk a quote from Teddy Roosevelt that I can't go over all of it, but it talks about the individual in the arena, and that the individual who strives gallantly, who errs, comes up short again and again, because there is no effort without error and shortcoming, but who does actually strive to do the deeds, who knows great enthusiasm, who spends himself in a worthy cause, and knows at worst if he fails, at least he fails daring greatly, so his place will never be with those cold and timid souls that know neither victory or defeat. I love that quote, because we all need to be in the arena. We all have to be embracing change to make lives better and to have a base of our tradition, but be willing as new information, new technology to change with the revolution that's going on in our lives today in medicine. And be in that
Everywhere.
arena.
Absolutely, get in it and be a responsible. Don't be passive. Be a responsible
Yeah.
participant. Be a driver in it. So two more lightning round. What's one screening test you wish every 35-year-old would just go get?
Um, well, I think going forward that everybody needs to know their risk, and the 35-year-old needs to know their inherited risk. And that's a combination of knowing their family history, not just moms and dads, but cousins, uncles, into several generations. And then if it's available, it's worth the money to know your inherited risk with a NGS testing, which, as you mentioned today, is getting to be affordable. That gives you your lifetime risk of genes you inherited. You can't change them, but you ought to know about them because now we can predict risk for different diseases, heart disease, diabetes, cancer, and so forth. And knowing that risk is the starting point for preventing life-threatening diseases.
All right, so last question. What is your advice for someone who wants to kick cancer's ass?
Know your risk.
Fantastic. Dr. Charles Balch, you are always a wonderful person to talk with and learn from. I wish you unbelievable success with the International Society of Oncology Prevention and Treatment. I think around the world, if everyone knows their risk and has access to screening and prevention interventions, we can actually turn the tide on cancer.
Well, thank you for the opportunity to talk to your wonderful audience.
All right, guys, that's a wrap for this episode of Kicking Cancer's Ass. If you enjoyed it, click subscribe. If you want more information, come on over to kcapodcast.com where we publish transcripts, we publish articles, resources, tools, and, keep everybody on their toes so they can kick cancer's ass. See you next time.